Welcome, everyone, and thank you for attending the Gansett meeting that's been going on throughout the day and will be going on tomorrow. Depending on where you are, I hope you have a good morning, good evening, good night, good afternoon. And thank you for joining this session. Today, during this session, we're going to talk about iron overload and inherited hemolytic anemias. We've talked about several disorders today: sickle cell disease, thalassemia, von Willebrand's, and some of these diseases require blood transfusions as a primary therapy. We know with blood transfusions, you can run into the issue of iron overload. And so during this session, we'll learn more about iron overload and ways to address it in treating sickle cell disease, thalassemia, and other blood disorders. I'd like to introduce our speaker for today. Our speaker is going to be Dr. Jacob Pendergrass. Dr. Pendergrass is an associate medical director of the blood transfusion services of the University Health Network and its affiliate laboratory partners in the Greater Toronto Area and Northern Ontario. He is an assistant professor in the Department of Laboratory Medicine and Pathology at the University of Toronto, where he holds a cross appointment with the Department of Medicine's Division of Hematology. He was the principal investigator of both a landmark prospective observational study of IVIG-associated hemolysis and the first randomized controlled trial of pre-transfusion diuresis for the prevention of circulatory overload. Other areas of interest include transfusion support of patients on extracorporeal life support systems and patients undergoing stem cell transplantation, hyperhemolytic transfusion reaction, and blood bank inventory management. Dr. Pendergrass graduated in 1999 from Dalhousie Medical School and completed his training in internal medicine, hematology, and transfusion medicine at the University of Toronto here in Canada before taking a staff position at the University Health Network. I'd like to introduce Dr. Pendergrass, and I look forward to hearing his discussion. Thank you.
Thanks so much, Dr. Ivy, for the introduction. I'm going to try to share my slides. Okay, and is it showing the right screen? Is it the slide or the presenter view?
Yes, it is.
Yes.
Okay, very good. Okay, so thank you so much for the invitation to speak on this topic. It's very interesting. It is difficult to discuss without getting kind of into physiology, and I'm going to try to keep it interesting as we go along here, because this is a really important issue for patients with inherited hemolytic anemias. Iron overload is, in fact, a significant cause of morbidity and mortality. And so understanding how it happens and how to treat the condition once it develops is really quite important. I am going to be mentioning very briefly at the end of this presentation a new oral iron chelator that is being currently subjected to clinical trials, and I am a co-investigator at University Health Network on that trial. So that's an important disclosure. So in terms of the objectives of this talk, we're going to talk about the pathophysiology of iron overload, like how it happens, what it does to you, distinguish the mechanism of iron overload in different types of hemolytic anemia. This is a really important nuance to understand that patients do experience iron overload in very different ways, depending on what is causing their hemolysis. And then we'll go through the different therapeutic approaches for patients who have developed iron overload to keep it from causing too much trouble. So before we can talk about iron overload, we should talk about how iron is normally managed in the body. And as this diagram shows, the iron in our body is split roughly in half between iron that is sort of in use, and most of what is in use is in our red blood cells or in the development of those red blood cells in the bone marrow, and a small amount is or muscle tissue. And then there's always a teeny amount kind of moving around between these areas. That's sort of the iron that's in use. There's a lot of iron that is in storage as well. And The two major storage sites are the liver and the reticuloendothelial macrophages. And the reason they have so much iron in them is that they're the cells that ingest the red blood cells when they reach the end of their lifespan. And they are responsible for breaking down the hemoglobin, salvaging the iron out of it, and then sending that back into the plasma where it can be distributed back to the bone marrow and to muscle where it needs to be. So you'll see that, the system operates with very little iron coming into the body at any particular time, like 1 to 2 milligrams a day are coming in, and very little is going out. Most of the iron we have in our body, we're just reusing over and over again. So how does iron control happen in the body? It happens almost entirely by controlling how much we absorb in our diet. There's actually no excretory pathway. There's no pathway that we can sort of turn on or turn off to get rid of iron. Only sort of what is lost, involuntarily through bleeding. And, that most cases that means just menstruation, but other times you can have bleeding from other things, or just sloughing of intestinal epithelium, which is where the dietary iron is kind of stored before it gets into the rest of the body. That's kind of how we manage our iron. It's just we turn on the faucet in terms of what is absorbed, but what goes out is just sort of passive. Importantly, that entire process of absorbing iron and moving it around is shut down anytime there is inflammation. Anytime the body is inflamed from something like that, there is kind of a lockdown on the iron. Nothing moves. And the reason for that is bacteria want the iron. And so this is a way of kind of starving bacteria of iron so that they can't replicate too quickly. It does mean when that's happening that you have a lot of iron kind of trapped in your storage system and not available for utilization. So that's an important aspect of iron metabolism. When you're looking inside the individual cell, in terms of how iron is kind of moving around, and this is generally true of intestinal cells where the dietary iron is being absorbed, and also those macrophages, which are picking up iron, and also the bone marrow, which is taking the iron and putting it into red blood cells. The basic pathway is you have your iron, which binds to transferrin, these little pink dots and the green dot. That binds to the transferrin receptor. The whole thing is internalized by the divalent metal transport ion. Within the cell, the iron is liberated and can then either be stored as ferritin or used for the cell's internal processes, or released back into circulation as required through something called ferroportin, or the iron door. So that's kind of the pathway, and then the transferrin is kind of recycled back out again. So there are a variety of ways that this system can kind of get messed up with iron overload. One is just by having too much iron in the body by transfusing too often. When you transfuse, you are loading a lot of iron into the body, and there's no quick way for it to get out again. And so you will accumulate iron the more you are transfused. And this is a map showing the blood supply globally. And that sort of corresponds to where you see a lot of transfusional iron overloads in places where you have a lot of blood to transfuse. Hereditary hemochromatosis is a type of spontaneous iron loading, mostly found in Northern European countries. It's due to an excess of the DMT1 molecules, so there's just sort of an excessive absorption of iron from the diet. African iron overload is kind of a combination of high dietary iron combined with a deficiency of the ferroportin protein, so it can't kind of get released again. And then there's this process called ineffective erythropoiesis. And we're going to spend some time talking about that because that's a really important cause of iron overload in congenital hemolytic anemias. And what happens with ineffective erythropoiesis is through some kind of interesting pathways. The ferroportin door is stuck open, and it's stuck open even when the body has too much iron in it. So normally the ferroportin door shuts when there's enough iron in the body and you don't absorb as much from your diet. But when it's sort of locked open, which is what happens with ineffective erythropoiesis, the iron just keeps pouring into the body and just keeps accumulating. So transfusional iron overload is something that you see in patients who get transfused frequently. And, that can be, from any number of different types of congenital hemolytic anemias, most particularly beta thalassemia and sickle cell disease. But it's a pretty straightforward proposition. Every time you get a unit of blood, that's about 250 milligrams of iron. And we know that you lose, maybe, 3 to 4 milligrams a day naturally. So if you are being transfused regularly, that iron will accumulate. And when you have your total body iron go from its usual levels of about 3 to 4 grams up to 12 to 24 grams, that's when you start developing problems. That's when you start having uh, organ damage. It's when you start having metabolic problems. Generally speaking, depending on how often you're being transfused and whether you are transfusing to replace blood that's being lost, you start to kind of worry about transfusional iron overload once you cross that threshold of about 20 units of red cells. That's when you'll kind of get up to that 12 to 24 gram mark, unless you're being transfused over a long period of time or you're transfusing to replace blood that is being removed from the body as well. Therefore, anything that can decrease the need for transfusion will decrease your iron overload. So patients who are regularly taking hydroxyurea have less transfusion requirements. Patients who take luspatercept and are responding to it will have less transfusion requirements. And therefore, in a sense, those are kind of treatments for iron overload. They slow down the rate at which the transfusions are leading to iron overload. But there's another type of iron overload that can happen even if you're not being transfused in situations where you have ineffective erythropoiesis. And what ineffective erythropoiesis means is that your bone marrow is trying to make mature red blood cells and it can't. The red blood cells are just not surviving to get out into circulation due to whatever genetic disease the patient has inherited. And when you have this ineffective erythropoiesis, what happens is the bone marrow expands in size. It fills up with all these very, very immature red blood cell precursors. And those red blood cell precursors secrete various hormones. Erythroferon is one in particular, that basically tell the liver to stop making hepcidin, which is normally made when there's too much iron in the body. They say, I don't care how much iron there is in the body, stop secreting hepcidin. And without hepcidin, the ferroportin door that I talked about before is stuck open and the iron just keeps pouring in. And it also is released into circulation from the macrophages, which have been eating the red blood cells. So it's not even being stored in a safe place. It's kind of flowing freely. It's flowing into the body from the intestines. It's flowing throughout the body through these macrophages. And essentially what this means is that when you have ineffective erythropoiesis, the massive expansion of those erythroid precursors creates this iron hunger within your bone marrow. And that iron hunger will override any attempt your body might normally make to try to decrease the amount of iron absorption that's going on and to try to shut down the internal transportation of iron. It vetoes it. It says, we don't care how much iron there's in the liver. We need more iron here in the bone marrow, but it's never enough because the red blood cells that are trying to incorporate that iron into their hemoglobin don't ever survive. So the quintessential example of this is beta thalassemia. So beta thalassemia is when you don't have enough beta globin being made, and beta globin normally pairs with alpha globin to make your hemoglobin molecule. And if you don't have enough beta globin, you have too much alpha globin. And that excess alpha globin is toxic to your developing red blood cell. That's what causes the ineffective erythropoiesis. You don't see this as much with alpha thalassemia. And the reason for that is that the excess beta globins can kind of stabilize themselves into hemoglobin H, which, although not a functioning hemoglobin, is not toxic to the red blood cell to the same degree. So it's really the beta thalassemia situations where this occurs. And you can kind of measure the degree to which this is happening by looking at something called the soluble transferrin receptor level. And so it's the soluble transferrin receptor is kind of the body's way of saying how hungry it is for iron. And that can happen when you're iron deficient, but it can also happen when you have a lot of ineffective erythropoiesis. And in a sense, the higher your soluble transferrin receptor level, the greater the mass of your bone marrow. And once you get to a soluble transferrin receptor level of about 10 to 25, that means that your bone marrow has expanded to 5 times its normal mass. And that's the point at which you start loading iron spontaneously. So if you look at this graph here, you can see that these black dots here represent the soluble transferrin receptor level of patients with beta thalassemia major. So these are patients who are being chronically transfused. And they're loading a lot of iron from the transfusions, but their soluble transferrin receptor levels are being kept relatively low. So it's shutting down or suppressing to a certain degree the spontaneous iron overload. But the thalassemia intermedia, who are generally not transfusion dependent, are still going to be loading iron because you can see their soluble transferrin receptor levels are very high. Their bone marrow has expanded a lot because they're not being transfused. And therefore, even though they're not getting that transfusional iron overload, they're still picking it up spontaneously. It will happen more slowly than with the thal major patients, but it will happen nonetheless. Okay. So what is the problem with too much iron? What does that do? So just sort of zeroing in on this part here of the intracellular trafficking of iron, you can see that there are various points at which the iron is just kind of loose. It's not bound to anything. It's not bound to transferrin. It's just sort of floating freely. So that's called non-transferrin bound iron. And you can measure that. That's a quantity of iron that is not stuck to a carrier protein. And when that's inside a cell, that's called labile cellular iron. And when it's out circulating in your plasma, it's called labile plasma iron. Why is it called labile? It's called labile because it is very reactive. Iron is actually a kind of a dangerous element within the body because it tends to undergo redox reactions in combination with various things like superoxide and hydrogen peroxide. And the net result of that are these hydroxy-free radicals. And these hydroxy-free radicals play havoc on tissues. They damage tissues wherever they bind. And this is how iron overload leads to problems. It's the labile plasma iron. Iron that is sort of tucked away in ferritin, iron that is bound to transferrin, that's fine. But it's the labile iron has exceeded the body's ability to kind of store it that causes problems. And there are sort of 3 cardinal organ systems that are affected by this. The first is the liver. This is where most of the iron accumulates during iron overload. It starts off here, and eventually the liver's normal storage mechanisms are overwhelmed, and the iron starts to damage the liver cells. And that shows up at first as inflammation. Your liver enzymes are elevated, then fibrosis, then cirrhosis, and then eventually hepatocellular carcinoma. The heart is also affected. At first, it starts off as causing dysfunction of the endothelium, so the ability to regulate blood pressure and blood flow is altered. Then you start developing arrhythmias, extra heartbeats, palpitations, pericarditis or inflammation of the lining around the heart or myocarditis, inflammation of the heart itself, and then finally pump failure, usually starting on the right side. So it starts off first as like swelling of your ankles and that sort of thing, and then eventually to your left side, where you start developing fluid building up in your lungs. And then the endocrine system is also very susceptible to this. These are relatively small organs. It doesn't take a lot of iron damage to shut them down. So hypogonadotrophic hypogonadism due to damage to the pituitary gland, hypothyroidism, hypoparathyroidism, adrenal insufficiency, diabetes, osteoporosis can occur from multiple different pathways. And the net result of this is a variety of different symptoms, fatigue, weakness, aching in your joints, swelling of your ankles, stomach upset, stomach pain, skin bronzing. It can be insidious. It takes a while to kind of manifest. It's not a sudden thing. It builds up slowly over time. So how do we know when this is happening? So the traditional way would be to do a liver biopsy, and that's where most of the body's iron is. So that'll give you a sense of how much iron is in the rest of your body, generally, is by checking how much is in your liver. This has now been largely replaced by quantitative MRI scans. which can generate an image, which various computer programs can then interpret as if it was a biopsy to find out how much iron there is. And whether you are looking at your liver iron concentration through biopsy or by imaging studies like the MRI, there's a pattern that you can see developing over time. So this black line here kind of represents what normal liver iron concentration is. It's sort of, less than 3 milligrams per gram dry weight. If you have somebody who is a homozygous carrier for the hereditary hemochromatosis gene, you can see that they start to accumulate iron past the threshold that you start having problems with cardiac disease and other organ functions, typically by around the time they're in their 20s, and then it sort of gets worse and worse and worse. But if you have thalassemia major, where you are being regularly transfused, you can see that the iron loading is much faster, and you can kind of get into end of life degrees of iron loading by the time you're 20 or 30. So the goal is to try to slow this rate of iron loading. And generally speaking, we don't try to get it down to absolutely normal. That kind of increases your risk of a toxicity from the therapy itself needlessly. So we just say if you can get it down to the level that somebody who is a carrier of the hereditary hemochromatosis gene has, because we know those patients don't develop disease, then that's generally considered to be safe. So we don't want it like less than 3 necessarily, but less than 7 is generally considered to be the threshold at which you will not develop problems with your liver, with your heart, with your endocrine system. So that's typically what we're aiming for, is try to get down to less than 7. And again, this is looking at the liver. For a long time, we assumed if we know what's going on with the liver, we can have a pretty good idea of what's going to go on with the heart. Now, as I'll talk about later, that's not always true, actually. You can be misled about how much iron is in the heart by only looking at what's in the liver. So again, the gold standard currently is to look at your liver iron concentration. If you can't do that, if you cannot use a biopsy or an MRI scan to diagnose this, you can look at the serum ferritin as a rough guide. And generally speaking, once you're over 1,000 micrograms per liter of your ferritin, that's when you sort of worry a bit about iron overload. Ideally, you should then confirm that by getting an MRI or a liver biopsy. 3,000 has been proposed as a better threshold for sickle cell disease, just because ferritin is an acute phase reactant. It increases whenever there's inflammation, and sickle patients generally have a chronic state of inflammation. For various reasons, a lower threshold of 500 might be better if you have something you're worried about spontaneous iron loading. Because in those cases, it looks like the iron is sort of being distributed in a more gradual way than if you have transfusion and it goes straight into your liver. The ferritin, again, can kind of generally tell you, what direction you're going in. It can give you a rough idea of whether you have achieved your goals in treating the iron overload, but it's a rough measure. So this is, one study of a patient. You can see that their ferritins, which is this blue line, are bouncing around quite a bit. You can see that they go up and down a little bit. They generally trend with the liver iron. But in this period here, the ferritin started to generally climb over time, even though the liver iron concentration was pretty flat. And that's probably because there was some kind of inflammatory condition going on here, causing the ferritin to increase, but without actually indicating progressive iron overload. So that's one of the hazards of using ferritin. It's better than nothing, but if you can get the liver iron, that's preferable. The other thing that has become apparent over time is that when you are accumulating iron in different tissues in your body, it happens at different speeds. Generally speaking, the liver loads iron quickly and the heart loads iron slowly. And the inverse is true. The liver can remove iron quickly, whereas the heart can remove iron slowly. And so what this means is that over time, particularly if you're starting and stopping iron chelation therapy, you are more and more likely to get a discrepancy between how much iron is in your liver and how much is in your heart. We don't currently have any kind of imaging studies to diagnose endocrine tissue iron deposition. For those, we generally rely on signs of, the function being impaired, looking at impaired growth charts, looking at symptoms of diabetes, for example, or symptoms of hypothyroidism. That's mostly how we do this. Uh, there are some studies out there that have looked at MRI scans of the pancreas, which can give you a general sense of your risk of diabetes, although it's not totally clear cut. You can develop glucose intolerance even with intact pancreatic function if you have iron overload. But you can see that this is a situation where the patient's liver iron increased fairly quickly. The T2 star, which is a measurement of cardiac iron, increased much more slowly. And even when it did start to increase, it was only sort of at the very end of it that you actually started to see that the heart function was starting to fail. So trying to diagnose cardiac iron overload by looking at your liver iron or by waiting until your heart starts to actually show signs of dysfunction is not ideal, because the liver iron doesn't always correlate with the cardiac iron, and cardiac function only fails as kind of a late finding with cardiac iron, sometimes too late for us to do anything about it. So this is why it's now increasingly common to use cardiac MRIs as well as liver MRIs to check the cardiac iron separately. And so again, the T2 star measurement is basically a measurement of how much iron there is in the myocardium. And you could see that when you compare the T2 star measurement with the strength of your heart, the left ventricular ejection fraction, it's once you fall to less than 20 that the risk starts to increase, that the heart is going to start weakening. And when you get down to less than 10, that's when it really starts to get more concerning. Interestingly, in this study, they were looking at predictors of patients who needed to go on heart medications. And they found that patients who had low T2 star measurements, there was a significant correlation. The lower your T2 star, the more likely you were to need cardiac medications. But that was not true in this study with liver iron. There was no statistical significance here. So you had a lot of patients who looked like they had pretty good iron control based on their liver iron, but who still needed heart medications. And that's because even though their liver looked pretty good, their heart had more iron in it. So again, the serum ferritin is also not totally reliable for this. So increasingly, we're finding, you really need to pay attention to the heart iron as well, like separately. You have to do that kind of on its own track. It gets even more nuanced, however, because it does look like some types of transfusional iron overload are more susceptible to cardiac iron overload than others. So we know that cardiac iron deposition occurs when your transferrin saturation is, basically near, at its capacity. And so the iron has nowhere to go, it becomes labile plasma iron, and that slips into the heart and starts to damage it. But for various reasons that we don't totally understand, that doesn't happen as much with sickle cell disease. Iron overload in the heart in sickle cell disease is really rare, even if they're being chronically transfused. It may have something to do with the fact that they are more inflamed, and essentially the iron is more locked down as a result. It can't get out of the cell that it's being held within. Patients with Diamond-Blackfan anemia appear to be particularly susceptible to this. They may have an inability to manage the transfusional iron overload. You can see that thal intermedia, it's a risk, but it's not as much of a risk as the thal majors who are being chronically transfused. So this has implications in terms of like, who do you need to do cardiac MRIs on? Generally speaking, we do it for our patients who have Diamond-Blackfan anemia or congenital dyserythropoietic anemias or beta thalassemia, but we rarely do it with sickle cell disease. We just don't seem to find it there. They can get it in their liver for sure, but not in their heart. Okay, what do you do once the iron is in your body? How do you get it out? So if you have a patient who is being chronically transfused, obviously you can't phlebotomize and remove the blood again. The whole point is to put the blood into them so they don't have life-threatening anemia. But if you then take a patient who was chronically transfused and you cure them of their thalassemia by stem cell transplant or by gene therapy or what have you, then they don't need transfusions anymore. And then you could start to remove the iron by simply taking a unit of blood off. And so this is one protocol where they were taking 1 unit of blood basically every 2 weeks. And they did that over and over and over again until the serum ferritin was less than 300. And then they went to like every 3 weeks. And eventually, they decreased the liver iron concentration from a starting level of 20 down to about 4.2. But this took a long time, like 35 months on average, to get all the iron out of the body. So although phlebotomy is easy, it's free, doesn't have any like side effects per se, it is kind of time consuming. You can see that like only 3/4 of the scheduled phlebotomies actually got performed for various reasons. And it's slow. It takes a long time. But that is definitely an option that you can use if you are not transfusion dependent and your hemoglobin is high enough that you can tolerate taking blood off. And that generally means a hemoglobin of 90. So sickle cell patients, in a sense, can undergo regular phlebotomies through their exchange transfusions. And if you have somebody who is being regularly given top-up transfusions, and instead of that, you take a unit of blood out first and then you transfuse them, then the rate of iron loading is maybe a little slower, but not much. You know, you're slowing the rate of iron overload from transfusion if you do a manual exchange. But if you do an apheresis exchange, that looks like it's much more effective. For various reasons, that can actually reverse iron overload. So if you have a sickle cell patient who has developed transfusional iron overload from top-up or partial manual exchanges, putting them on apheresis exchanges, if that's an option, is actually one means of decreasing the amount of iron you've already accumulated. Doesn't work for every single patient. I have had a couple of patients that doesn't seem to hold, that they still develop iron overload even by apheresis. But for many patients, that's actually an effective iron reduction strategy. Okay, now we can get into the actual iron chelators. So the first iron chelator was desferrioxamine or desferrol, and this was synthesized from a bacteria, Streptomyces pilosis. If it was put into an iron poor environment, it would start making a lot of desferrol molecule to kind of find iron and bring it into the body, the bacteria's body, that is. And if you can purify this substance, you can use it as an iron chelator. It's a very potent iron chelator. One molecule of desferrol can completely neutralize 1 ion of ferrous iron. However, it's a big molecule, so that doesn't get absorbed well by orally. It means you have to give it subcutaneously or intravenously for it to get into your system. And unfortunately, once it's in your plasma, your body is very good at getting rid of it. Like, like within minutes, the desferol that you've infused has been cleared from your body. And what has been found, and it took a while to realize this after this drug was licensed, is that you have to have this given over long infusion periods, like minimum 8 hours. And so this is looking at the different infusion times and the amount of iron that was being put out in the urine. And you can see that if you sort of give it as a bolus over like less than 8 hours, not very much is given. Over 8 to 10 hours, you get much more excretion. And then it kind of plateaus a little bit. More than 8 to 10 hours, less benefit. If you do give it as an 8 hour infusion, you can see that you have progressively more desferrioxamine and then ferrioxamine, which is the desferol bound to the iron, accumulating in your body, and that will sort of slowly wick iron out of your tissues. And most of the drug, whether it's bound to iron or not, is excreted in your stool and in urine, about 50-50. So it took into the 70s to figure out that this is how you needed to use this drug. And it needed special needles, special infusion pumps, not a lot of fun. And if you're not able to keep up, like if you can't get enough desferol into your body to counter the amount of iron that you're accumulating from transfusion, then you are at greater risk of death. And so this is a study, that came out in the 90s. It's just an observational study, but they found that the patients who were more likely to get into trouble were the ones who were starting with a high degree of iron overload before they started the desferol. And then when they started the desferol, they just were not taking enough to keep up with the amount of they were being transfused. And so these are the patients who didn't survive. If you were taking it to keep up, then you were all right. If you were actually starting with a low iron level, then you had some time. But again, it just showed that if you don't keep up with the infusions, eventually it will get you. Some studies have found that once you develop heart failure from iron overload, you really are in trouble. Half your patients, once they actually have clinical heart failure from iron overload, will not survive more than a few months. There is a possibility, though, that if you jump in with a 24-hour, 7-day-a-week continuous infusion of desferal and you leave that thing running for like a year, you can sometimes salvage these patients. You can quickly shut down the amount of labile plasma iron so it doesn't cause the arrhythmias, and then you can gradually kind of wick the iron out of the heart. So this is an important thing that desferal can be used for as sort of as rescue therapy to save somebody who is just about to die of heart failure. So in general, this has been a life-saving medication. There's no question about it. If you look at survival curves of patients with beta thalassemia major in Italy, looking by the year that they were born, you can see that over time, if you go from the 60s to the 70s, in this case up to the 80s and 90s, life expectancy got higher and higher, and that's totally from desferal, and specifically death from heart failure became less and less likely over time. So it's a great medication and has saved many, many lives, but it is not fun to use. These subcutaneous infusions can hurt. Although the 8-hour overnight infusion is usually enough to sort of get iron out of your body effectively, when you're not running the desferal, your labile plasma iron will rebound and then it can kind of sneak from your liver back into your heart. And so this is one of those situations where you look like you're making progress, but in fact, your cardiac iron is actually getting worse over time. You can use a port, like a PICC line or a portacath, if you don't like the subcutaneous infusions, but those are at risk of clotting and infection. The drug itself has side effects of causing night blindness or even complete blindness, loss of color vision. Hearing loss can happen if you overchelate with desferal. It's not a fun medication. And so, after years and years of living with these desferal infusions, both patients and their caregivers really needed an oral iron chelator, something that was just easier to take. And the first one that was developed was deferiprone. And deferiprone is derived from a compound that is found in many different plants. Like this is the larch tree. That's one source of deferiprone. Easy to make. It's kind of a simple molecule. And it was first developed in the University of Essex in the 1980s. The industry that started this felt that there was maybe too narrow a therapeutic window on this, that the side effect risk was too high, so they abandoned it. But then that was kind of picked up by other individual investigators, other hospitals, and people started kind of making it in-house because it's a relatively simple molecule. It does have problems, and one of the concerns about it initially was that it might cause liver fibrosis. And because of the controversy that arose out of that, and this was, kind of a notorious series of legal cases, it never really had a proper phase 3 clinical trial. And without a phase 3 clinical trial, many regulators would not approve it. But in other parts of the world, where people decided, it's better than the desferal. It was developed, and so it kind of has this kind of funny rollout where it was approved in India and the European Union, 10, 20 years before the US or Canada approved it. And so that's resulted in some interesting data because now we have studies of actual patients in the real world using this, not in a phase 3 clinical trial, but in a post-marketing or phase 4 clinical trial. And what this showed was that it looked like it was not as effective an iron chelator as desferol. People were excited at first that it would be about the same because the amount of iron being excreted in the urine was about the same between those two drugs, but it turns out there's very little fecal excretion of iron with deferoprone. So it looked like actually it was going to be about the same, but it's actually weaker. Um, and then there are all these other risks of neutropenia and arthropathy. So this drug was sort of kind of losing its place in the world. It looked like it was just not a great drug until, interestingly, we started doing cardiac MRIs, looking at cardiac iron, and then we discovered that deferoprone is actually better in some ways than desferol. And so this was a study looking at patients who were getting deferoprone versus desferol on their cardiac iron, and the cardiac iron was cleared more rapidly with deferoprone. So this gives it a whole new possible application. Um, so it's still not our favorite drug, because although the concerns about hepatic fibrosis were not confirmed, it does cause neutropenia, it does cause arthropathy. Um, and it's not as good as at reducing iron in the liver. But for patients who have a lot of iron in the heart, this drug is particularly useful. And when you use it in combination with desferol, it's even more potent. And what people think is happening is that when you use the two drugs together, the desferol can't get inside the tissues as well. The deferoprone is a small molecule, so it can kind of get in there, bind the iron, bring it back out, and then desferol can then grab it and fully neutralize it because desferol is a hexadentate and very potent iron chelator. And then the deferoprone can kind of be recycled. So it can kind of go bringing the iron out for the desferol. The desferol is being continuously infused and excreted. And this is a very effective way at reducing cardiac iron when you use these two things together. So that was kind of the story of desferol and deferoprone. Meanwhile, while this is all happening, the company that had initially developed deferoprone started working on another iron chelator. This one they didn't try to derive from bacteria or plants. They had sat down with a computer system and came up with a modeled molecule that was orally available, had a pretty good half-life as it bound to protein, so it wasn't excreted as quickly. Um, and and it looked like it was relatively easy to take. You just sort of dissolved it in some water or juice, took it on an empty stomach. You just needed to take it, once a day. Looked great. And this one did get a phase 3 clinical trial, and it showed that it was equivalent to desferol in reducing your liver iron. There was some renal toxicity noted, but they felt like, well, this is manageable. You can adjust the dose down a little bit, or try to treat the side effects of the kidney. And on that basis, it was approved and licensed in 2005. It was discovered in the real world, though, that patients really did not like this drug. It's caused a lot of side effects, particularly stomach upset, and people just weren't taking it. And so the company came out with a new version of it, Jade New, or Type J, if you're using a generic type of deferoxarox, and that was approved in 2015. And that it does appear to be less likely to cause stomach side effects. What about the effect on cardiac iron? So one study found that if you're starting with a liver iron of say like around 10, then you will have a nice steady reduction in your liver iron on the XJade. And your cardiac iron, if you're starting sort of like around 10 as well, will also get better. So that's what we want to see. Liver iron gets better, the cardiac iron gets better. However, there was another population of people that if you started with a really high liver iron concentration, even though the liver iron would go down over time, the cardiac iron would actually get worse. And that was a very surprising finding that it looked like it was actually worsening your cardiac iron, even as it was improving your liver iron. It's kind of almost the opposite of deferoprone. Deferoprone's not very good at the liver, but great at the heart. For the XJade, at least for patients who are severely iron overloaded from the beginning, it looks like it's better for the liver than it is for the heart. Other studies have found that if you're starting with really high cardiac iron as well, that the deferoxarox is just not as effective at improving things. It's just it can definitely make a difference if you're sort of have moderate cardiac iron overload, but if it's really severe, it looks like it does not have much of an effect. And if your liver iron concentration is greater than 7, those patients will also not improve their cardiac iron right away. Generally speaking, once your liver iron is less than 5, then it looks like the cardiac iron starts to get cleared. But again, it just showed that this has some cardiac iron chelating capability, but not an enormous amount. So what do we do with all this? How do we sum all this up?
Hey, Dr. Prendergast, I just wanted to give
Yes.
you a 2-minute notice.
This is like my second last slide, so I'm almost done. We have deferoxarox or Exjade. This is usually our first line therapy. It's expensive, but it looks like it's the easiest to use, and it's effective in most patients who do not have severe iron overload. If you do have severe iron overload, like if your liver iron is greater than 20, you might need desferol, or if you're going into heart failure, you might need desferol. Not something you want to do as first line therapy, but if it can kind of bring you back into a safe zone, at which point you can start taking your deferoxarox. And then deferoprone is usually for patients who have severe cardiac iron, either by itself or in combination with desferol. You do have to monitor this medication fairly carefully for like the neutrophils. So they all have their place. These are the 3 that are out there. This is the new one that is currently in clinical trial. This is also a bacterially derived iron chelator and also very orally bioavailable. It's like deferoxarox, but when they tried a phase 1 clinical trial, it still had some renal toxicity. That trial had to be stopped. They're starting a new phase 2 clinical trial, thinking that, well, maybe we don't need to give as much, like maybe only 3 times a week. So we'll see. We'll see how this one pans out. But right now, there are 3 licensed iron chelators available. Okay, that's the end of my presentation. I don't know if there's time to take any questions, but I'm happy to entertain them.
Thank you so much for that presentation, Dr. Prendergast. It was very informative. We know that, as you pointed out, with thalassemia, iron overload can be a major issue. And then with some of the therapeutic treatments for thalassemia as well as sickle cell disease, we see that making sure that iron overload doesn't become a major issue it is something that we definitely have to keep in mind on. I do appreciate that you also said that using certain strategies such as apheresis may help to lower that iron burden, and so that would be optimal. But we know in certain low resource environments that may not always be possible.
Available.
And you talked about thalassemia, and so of course they can have an anemia. So is it ever possible to treat iron overload by phlebotomy in a patient that has an anemia or that's anemic?
So generally speaking, we want the hemoglobin greater than 90 before we start doing a phlebotomy, just because we worry that the patient will just feel totally wiped out, having their hemoglobin lowered less than that. I have had some patients whose hemoglobin are in the 80s, and I try phlebotomizing like half a unit. Now that's going to take the iron out of the body very slowly, but for some patients that's better than going on an iron chelator, particularly if they have like renal impairment, which means that they can't really take desferol or Exjade. So it kind of depends on your patient. Like that rule of 90 is kind of arbitrary. That's sort of what we use for protocols. But if you have a patient whose hemoglobin is in the 80s or even less, you can try taking off a small amount of blood, just like every couple of weeks, take off half a unit or so, and you will eventually reduce the iron that way.
Wonderful, wonderful. And I know you talked about it's important to monitor iron overload. We want to make sure that we're looking at iron accumulation in the heart and the liver. But we also know that a lot of our patients may be in a low resource setting, and in resource settings, a magnetic resonance imaging scan or
Yeah.
MRI is the best way to monitor that iron overload in the heart and in the liver. But in low resource areas, or when you don't have access to an MRI scanner, what would be the best way to monitor that iron overload?
So probably your ferritin is your best option, just to kind of get a general sense, knowing that it's going to bounce around a little bit. and knowing that if your patient gets sick with something, like, if they develop an infection or an injury or have surgery, that the ferritin will shoot right up. But that doesn't mean they're developing iron overload. So you just have to contextualize that measurement. But also, I mean, even while you're checking your ferritin, that's really mostly a measure of your liver iron still. So if you can't get a cardiac MRI either, even just an echocardiogram, is something. You'll have to look at it pretty keenly to pick up very subtle signs of cardiac dysfunction from iron overload. But you can get something from an echo, even if you don't have an MRI. And
Okay.
then, as you're able to check things like your fasting blood glucose, check your TSH, check your testosterone levels, ask your patient about their periods. All those things are important to look for endocrine dysfunction.
Wonderful, wonderful. Now, we do have a survey question that we want individuals to fill out, and that will be uploaded. So we will upload the survey question. While we're doing that, though, and while individuals are taking the poll, I think we have time. I did want to ask one other question, if you don't mind,
Sure,
Dr. Pendergrass. So,
sure.
so now, fortunately, it looks like there might be gene therapy, and including for thalassemia, for sickle cell disease. Um, do you anticipate that, hey, individuals that have iron overload, there will be some type of complication where they're not allowed for gene therapy because they have
Mm.
such iron levels, or because they might have damage to their liver or kidneys? Because we want to make sure that patients have that consideration to say, hey, I need to have my iron levels in a good state before these gene therapies. So could you just talk to what you think iron
Yeah.
overload might have on gene therapy?
I think the inclusion and exclusion criteria for gene therapy are still kind of being worked out a little bit. Um, I would say that, iron overload is not a contraindication to it unless it has resulted in really kind of end stage, liver cirrhosis or heart failure, in which case, that in of itself might be more life limiting than the thalassemia that you're trying to cure. But also, will make it harder to tolerate the chemotherapy you have to undergo to have the gene therapy. So, if it's really end stage, like just kind of palliative level iron overload, it probably is going to be a contraindication. Otherwise, it wouldn't be a contraindication, but you might want to, really spend some time really getting on top of that iron overload to prep your patient for it. You don't want to be hitting your patient with lots of chemotherapy that can cause liver damage, that can cause heart damage if there's a lot of iron in there already. So you want to kind of get that out of there first. And that might take like 6 to 12 months, of really intensive therapy to kind of get yourself prepped. But you can do it. So I wouldn't say it's an absolute contraindication in most cases.
Okay. And just my final question. I don't see any questions in, well, I do actually. I'm sorry. Oh
Hmm.
no, that's someone saying sorry for joining late. I do have one other question, but probably on the other end. So with sickle cell disease, there's hydroxyurea and there are other therapies, shy of gene therapy. We know that with gene therapy, you do have fertility issues to think about and others. And we know that with iron, with thalassemia, we have treatments there. Of course, the blood transfusions. What advice would you give to someone thinking about gene therapy for the treatment of the disease, where iron overload would become a consideration?
Sorry, in terms of fertility specifically, or
Not fertility, but at what stage would you say, okay, be would you consider iron overload as a reason to say to really suggest someone get gene therapy? So if their sickle cell disease is so severe, they're having like strokes or so forth, you might consider gene therapy. Is there a situation where you might say, okay, well, your iron overload is becoming so severe, we would prefer you move to gene therapy instead of the other therapies that are available?
yeah, that's a really that's a tricky question because um, generally speaking, if you've developed iron overload, uh, that means that you haven't really been compliant with your iron chelation therapy. And there's a variety of reasons why that might be. It's uncomfortable, it's disruptive in terms of life schedule. But if you have somebody who cannot comply with iron chelation therapy, one could argue that they're maybe going to be more prone to complications of the gene therapy because they won't be able to take the other medications as well. That's a tricky one. It's a tricky one. If you have two patients, one who has been religiously taking their iron chelation therapy, suffering through it, but have kept their iron overload under control, and one who's been sort of not super reliable about it. If this is a limited resource, like which one gets it? The one who was really doing their best to get the iron overload under control, the one who couldn't do it. That's kind of almost an ethical question in a way. But from a strictly medical perspective, which patient is likely to have their life saved more by the gene therapy? For sure, the patient who has iron overload, even if it's because they haven't been compliant, that patient is more likely to have their life saved by gene therapy than somebody who has been, very diligent about taking the chelation and has kept their iron overload under control.
Okay. And we do have one, there was a question that came in, so I want to quickly read this one and allow you the chance to answer. There was a question about, can food cause too much iron storage in body, especially for sickle cell and thal patients? And can iron medicines also contribute? So if someone's taking excess iron as a supplement.
For sure. I think, again, the body is usually pretty good at controlling how much iron it absorbs from diet. So if you're like, eating like a lot of meat, for example, you're not likely to develop iron overload from that because when your body has enough iron, it'll simply stop absorbing it. So unless there is something awry with your body's, regulation of that iron absorption, i.e., if you have like a hereditary hemochromatosis condition or African iron overload, or you have this ineffective erythropoiesis like beta thalassemia, you don't need to worry too much about your diet. Now, if you do have a condition where your body's ability to regulate how much iron you absorb from your diet is not working properly for various reasons, then yes, taking extra iron by mouth, extra food or what have you, will make it worse. Certain things like tannins from tea can slow the iron loading. So it does probably make a bit of a difference. Is it a huge difference? Like, I don't know. I'm not sure you'd be able to completely shut down any iron absorption from your diet entirely. But, certainly, the less you eat, the less you'll absorb if you have that kind of regulatory deficiency, like someone with beta thalassemia might have.
Great. Thank you so much, Dr. Pendergrass. It was a wonderful presentation. Unfortunately, we are at time. I did see a question come up in the Q&A, and I don't know if you can answer that just outside of this, but we do have to end this session right now. I'd like to thank everyone for joining this Gansett session. Please stay with us for the rest of the day and tomorrow. There's a lot to learn about improving care for individuals with inherited blood disorders. So it's wonderful that you're here to be part of the solution to help as we look for strategies to improve care for individuals wherever they are throughout the world. Thank you.